go ahead and get started. Thank you all for joining the Weill Cornell Medicine Clinical and Translational Science Center AI seminar series. We're incredibly pleased to welcome Dr. David Dorr from OHSU today. Dr. Dorr is professor and vice chair in the Department of Biomedical Informatics or of Medical Informatics uh, and Clinical Epidemiology at OHSU, and he's also the Chief Research Information Officer. Dr. Dorr earned his undergraduate medical degrees from Washington University in St. Louis, followed by internal medicine and biomedical informatics training at the University of Utah. And then he joined the faculty at OHSU. Dr. Dorr and I have collaborated on a number of manuscripts together about informatics to support scientists across the CTSA consortium. And it's been great to work together, and it's great to call Dave a friend. So, Dr. Dorr, we're very happy for you to be here. Please take it away.
Great. I really appreciate the invitation, and Dr. Campion is one of my favorite people in this field. So thank you for the invitation and overall. So I'm going to talk a little bit about what I see as an evolution that historically is substantial. Um, And although somewhat potentially disruptive, also promises a lot of opportunity and how we're approaching this at Oregon Health and Science University. So a lot of people help me with these slides, some of which I try and give credit where it is. But our goal at Oregon Health and Science University right now is really to take the concept of learning health systems, which I'll describe, and embed some of the opportunities we see from new generations of artificial intelligence and machine learning, not just generative AI, but I think that's actually a key driver here, but also in terms of trying to get to the place where we can start to apply multimodal AI systems. So I've received funding from a number of federal agencies and foundations in the past and presently. And this doesn't represent their views, obviously. And the one thing that I often say now about AI is because the FDA has lots of thoughts about AI, is that some of the things that I'll be discussing could potentially be under FDA jurisdiction, but I'm not sort of promoting or discussing ones particularly, but I do want to highlight that. So I just want to start by acknowledging this sort of crucible that we're in right now, and Oregon Health and Science University is actually in a similar boat in that, with the pandemic and with sort of ongoing pressures to the system, that we're seeing worse health outcomes and costs continue to be high in our system, significantly high in the over the U.S. as a whole, for sure, but also for us living in Oregon, we see a lot of problems with hospital and ED throughput and boarding and difficulty with access to care. That is an ongoing issue for the United States, but seems to have gotten worse. And then on top of that, with the constant pace of change and demand in this busy world, we see a lot of burnout in our providers and care teams in general. And that's a significant issue for us. We also are struggling a little bit to keep up some of our quality measures. This is from Vizient Um, and I think this is sort of a common issue for some places. As these pressures grow, it's really hard to maintain the quality that you'd like. And so we've seen some significant reductions in some of our metrics, in addition to with the cost pressures in our regions, the legacy health system, which represents several hospitals and a large base, has reached a point where it looked no longer economically viable, and OHSU is looking to merge with them. So we're sort of in a perfect storm here. But what's interesting is with disruption, I think comes some opportunities. And with a number of new technologies we've seen, we, for perhaps the first time in at least recent memory of my informatics career, people are very excited about using some new technology tools. Probably you are using these if you're a clinician there. And these are, for instance, ambient AI scribes or tools that might summarize large amounts of information for you or allow transcription or translation of different tools, not only between languages, but or narrative text, not only between languages, but also in terms of changing the tone or approach, the level, the literacy level needed for them. And so we see this as an incredible opportunity, but there's so much out there that we really sort of felt like, hey, we need to be conscientious about how we move forward. Um, in addition to the generative AI, we also see we're right at the edge, I think, of many of the great uses of multimodal genomic imaging, other data, AI, machine learning to be taken up. Uh, and we really wanted to say, well, how do we do this well? Because there's a lot of promise, but there's a lot of risk as well. And our answer to that is really embed these the planning for and implementation of really our strategy around AI in the learning health system. So I'll talk about that. So really have four objectives: talk about learning health system, talk about what I mean by AI ML, um, and some of the issues around that, and why and how why we decided to become this AI-enabled learning health system, what we're specifically doing, how we're organizing around it. And then my hope is that as you hear some of these ideas, you can go back and think about how do I apply this. It's very relevant for clinical and translational science awardees to be thinking about this because the newer, I guess now, call that pays for CTSAs has learning health system components as a core part and clinical and translational science innovation, right? So really advancing the science, which we think there's ways AI can do that too. So what is a learning health system? Basically, this is a system where science, informatics, incentives, and cultures are aligned for continuous improvement, innovation, and equity, really trying to make it easier to understand what is happening in your health system by consistently and continually analyzing your data, identifying gaps, understanding performance, integrating knowledge, and bringing people together to design interventions that can transform the delivery of healthcare and improve human health. This came out of sort of an idea that's been around for quite a long time, much longer than 20 years or so, of continuous quality improvement, where you do small tests of change, and really sought to say, how can we make this more rigorous, more sustainable, more impactful? And so in a learning health system, there's sets of capabilities as well as a set of processes that take place. A learning health system, as shown on the right, also starts with formation of one or usually more learning communities that get together to really say, what are we trying to do here? How well are we doing it? And how can we learn how to do things better, both from understanding our own information, but also bringing in other knowledge about it. So for us, we think about implementing this as really identification, prioritization, and taking action, right? You can't do everything. But if we think about ways that we can identify more opportunities, we can bring in more knowledge, and we can and try and stimulate innovation, sort of this ability to redesign, then we can prioritize based on the value that they bring, their feasibility, the impact they have across multiple outcomes. And then we could take action. And a lot of the action that's enhanced compared to continuous quality improvement is really much better understanding of how to do robust and rigorous evaluations that are also pragmatic and can be implemented in routine care and implement change strategies that are proven to work through understanding of implementation science. So this is sort of the definition that we want to strive for. I think for learning for academic health centers that focus on clinical excellence, research, and education, this is crucial, right? You really can't have all of these without that. And really the goal of these, a different way to show it here is, analyzing your data, integrating evidence, and then sort of generating, ideas about improvement, and then implementing those and understanding what you've done focuses on a broad set of outcomes as well, not just improving health, but the experience of patients and clinicians, addressing cost issues and equity across this quintuple aim. And I'll show you an example of how we've addressed that. So, this impact can impact each mission. And this is from an article that sort of highlights some aspects of this. And I'll go through two other examples that with which some of you may be familiar. But really, what we think about here is to really achieve clinical excellence, you need this ability to engage people, to innovate, to improve, to implement new knowledge as it comes in. You also need to tap into your research capabilities to really drive their impact. And at this point in time, to make them sustainable, right? How do you get researchers engaged in this kind of work? And then for education, especially as these new tools come on, like generative AI, we really are trying to train people to take those leadership positions to drive the next cycle of this. And there's an expectation that there'll be sort of this pressure of constant innovation as these ongoing challenges that we face come further to a head. So I'll give you some examples. One not too far from you all that Leora Horwitz and now Devin Mann have worked on where they got funding to do pragmatic clinical trials. So identify a set of issues that they wanted to address, perhaps from health system priorities, but then they built ways to do pragmatic clinical trials. Now, that isn't just what a health system is about, but the one thing I will highlight is that, with a really rapid approach to this, you can do mini trials, and I'll highlight a little bit of our experience doing that as well. You can also focus on, learning such that these programs can pay for themselves. And I'll give you some examples of this. By combining outcomes, in this case, for instance, this second one about increasing smoking cessation, like trying different versions of a best practice alert here, they were able to show, okay, this way of reminding people was most effective. And then as part of this study, they were able to add a charge, right, for smoking cessation that we know. So you can build in the sustainability into by thinking about those multiple outcomes that you're wanting to achieve. There's other savings that they provided. Um, but not all of these were successful, right? So, trying to reduce readmission rates with telephone calls, for instance, which has been done now quite frequently, including in very large scale studies, it's really hard to sometimes impact these outcomes. And like traditional quality improvement, we expect that not everything will be successful. It's really, are we generating the evidence about the actual success, addressing some biases by having the randomization embedded into routine care in a pragmatic way and doing rapid cycle innovation for prototyping and design. So one I really like, and I highlight this because this is actually quite important to us, from Dr. Desai here. They looked at prescription benefit recommendations to reduce out-of-pocket costs for patients. So actually, these are quite important. And this is an interesting thing for us because if people use our pharmacies more, we know if their prescriptions get filled, we know the exact cost. And if that makes sense to them, we can sort of recommend that. So we're interested in this kind of thing. What they had is really understanding what the relative cost is overall, and then trying to say, can they reduce that cost by in a group where they offer specific recommendations at the time of prescription? And indeed, in this randomized controlled trial, about 200 clinics, they were able to show that the cost was about 11% lower. And what's interesting that is that that's really important to the people we serve, but also for us. We can recapture some of that through system-based changes. So that efficiency and effectiveness, lowering the cost for them can be very helpful for us in understanding the benefit. Similarly, there's another study that they did again, another group did where they focused on alerts for mineral corticoid receptor antagonists in heart failure, providing alerts, providing messages at a population base, or just doing usual care. And what they showed is these alerts actually generated more prescriptions versus messages, but both of those were better than just usual care. And the benefit of having these multiple arms that can be implemented in routine care is you can also start to think about, okay, what are the unintended consequences of these? And where is the right solution that might, in this case, limit alert fatigue, where you're trying to give alerts across everything. So having a ability to rapidly test these things and then decide what is working, and how well can it work, and then what are the balancing measures for that are incredibly important. So really, this is like, how do we create a pragmatic clinical trial approach that can sort of think about this as we're trying to implement these in care. Similarly, at Vanderbilt, with whom I've worked a fair amount over the last decade or so, they did a number of really crucial studies. The second one on this list had multiple New England Journal articles around saline or balanced crystalloids. Now there's been a shortage of both of these recently, but in terms of reducing mortality, acute kidney injury, and renal replacement therapy needs in people with kidney injury, and they were able to implement just through a alternating over time different order sets where one versus the other was defaulted for these different both for the ED and the ICU, and demonstrate finally that people had lower mortality with balanced crystalloids in this particular group. So, that the one thing about what they did similarly is it's rapid prototyping, it's implemented in routine care, and that enables us to generate so much more information. So we got very interested in that. And we started down this learning health system path, a couple of us at OHSU. And what we found is that the new capabilities for AI were really driving us to need a different approach. So, for the way the health system usually does evaluation of what, generating quality improvement or implementing clinical trials, often those are more separate than they need to be. But in AI, we found a sweet spot where we really needed to know more about the impact of um, these new algorithms and tools in part because they are such black boxes. Their ability to generate very human sounding responses is, as we know, amazing and to be programmed with simple um, prompts. Um, and they look like they're producing cognition, although they're just complex black box prediction engines. But they have errors that were hard to predict and could be significantly problematic. And the example, as I'm sure most of you know, is these large language models that once they reached a level of complexity, having been trained in a generalist sense on billions of documents of narrative text, started to be able to take very complex human language-based tokens of increasing size, so you could really feed substantial inputs into them and then produce back out a variety of outputs that were based on predictions, but were based initially in plain language. So, and you could, sort of that language could be altered by what you tell the system to do by tuning them, but also by changing the prompts for them. So, and these are they're very expensive to train. So all of a sudden we were faced with these other companies, this industry were developing these very complex and amazing sounding models and then offering us products for them, as many of you found. At the same time, uh, I, other machine learning, like digital pathology, like radiology, and others, were advancing to the point where the real benefit of these tools could be significant. But the way to implement them, the successful implementation strategy, that sort of implementation science of how you do this, especially when it's really transforming workflows, like for a radiologist to get a reminder about these tools or an alert that this for a trauma team to get an alert that there's this patient's chest x-ray has a pneumothorax in it. None of these algorithms are perfect, of course, and if they're replacing some of the cognition done by humans, we really have to understand what the impact of that is, given the fact that they're problematic. These are much more complicated to implement than the generative AI, but perhaps more impactful over time in terms of really transformative effort. So at OHSU, we formed an AI governance committee, which I'll talk about as these came out, sort of went to our executive leaders and say, these are transformative. People are demanding them. We have 165 requests in like just over a year, actually, a little more than 8 months. And what we found is that these uses had a couple things in common. One is the very promising uses could be categorized. So although there's 165 requests that they really do certain things well, like transcribing and transforming narrative information, right? Um, and providing, in some cases, interactive messaging capabilities like chatbot-based capabilities. But when vendors would come to us, they had very little concrete evidence about how well they worked and when they didn't work. And so with that, we were able to sort of capture most of these in terms of, ambient AI scribe that I'll describe in a bit, transcription, translation, concept extraction, and summarization, where it takes a large amount of text and then sort of gives you the highlights of it that I'm sure you've all used this for, in addition to our AI, broader predictive modeling and sort of create a strategy around these are the ones we need to do, but we need to be able to evaluate them effectively. And I'll just give you a very simple example of sort of the evaluation that I think can be done in a very straightforward way. So we took a group of different learners and some attending faculty. And we taught an open source LLM to take discharge summaries and other patient information and then summarize the what happened during a hospitalization as though you were scrubbing the chart for an outpatient visit. So we sort of divided that up into like you have data and tell us about the data, then put that in the patient context for information, then add your knowledge about what guidelines are important, and then sort of step back from a holistic state and talk to us about wisdom. So these two examples here, A and B, one is from a large language model, Llama, which is an open source one from Meta, and one is from a human. So we had humans produce these as though they were scrubbing the chart. This is actually what I do with the residents in my clinic. Um, and one is from an LLM. So if people want to just type in, first, which they like better of these two, which you think would be a better summary. Then we had people rate them in sort of blindly for on a scale of quality. So is A or B better? Do people think? You could just type it into the chat there. I'll put my answer there. Um, you can think that. And then one of them produced by the LLM and the other one produced by the uh thanks, people are saying it. Well, yeah, so oh good. So Jeff, thank you. B is better for a layperson, but A is better in terms of efficient communication of input. That's a crucial point. Okay. Now guess which the LLM did and which the human did. And I randomize let's guess which is the LLM, A or B. Yes. Everybody knows it's B. Yes. So obviously, so we then evaluated these on accuracy, synthesis, usefulness, and succinctness. So how brief it was. And so the AI had quite good scores on accuracy, on the ability to synthesize the information, and then perceived usefulness. So mostly improved across each of these categories. The data it produced was actually not as useful, but so we removed that one. But information and knowledge and wisdom were, in fact, perceived wisdom was slightly better. Wisdom is sort of a person-centered care planning approach where you're taking a holistic view. And it did a pretty good job of identifying those key issues where there's complexity. So it was amazing, right? And I think we've all seen this, and we've seen a ton of examples of real, changes, efficiency changes, diagnostic time, less time at the keyboard using scribes, and then reduction in mortality from ECGs. But this level of evidence is just not to the point where you can count on them. So how do we know both how to implement them and what we'll see when we do? And that's really what we did to start this initiative. So one thing that is also amazing about these is this is a screenshot from Epic that is all their generative AI because the implementation of these tools is incredible because you can do prompt engineering and just connect a single API, sending narrative information and the prompt to this generic large language model or a specific one in your case, you can apply it in so many different ways. And so, Epic has implemented that. I have agreement with Microsoft to do this. And so like implementations as easy as, turning on a switch and writing some prompts and then sending it out. Now, it turns out that is complicated but compared to some of our implementation strategies for innovations, there are many things we think we can do simply if we can do it well. The problem with doing it well is we have to know the errors, right? So historically, when you install machine learning, you have significant differences from the training site to an operational site. The impact when you're wrong, either when it's a false positive or false negative, how well you can explain this, which is incredibly difficult with some of these models. Um, and how can the person know when the algorithm has low confidence? Um, some examples of how this impacts the implementation, I think, are incredibly important. And automation bias is our byword in using some of these tools. It's true for large language models and for certain imaging or multimodal. This is in mammography, where basically if the algorithm that's trying to detect a potential tumor is wrong, a false positive, um, people are likely to believe it because it appears to perform so well. But the less formal training you have, or the less experience you have, I'll say, the more likely you are to inappropriately believe it. So, as you sort of increase your training, you tend to correctly say, "Oh, it's wrong in this case." But how do we address that? How do we provide uncertainty quantification? There's a very large ARPA-H effort around this that just got submitted. We were a part of, but it's a crucial issue, and what all we can do right now, for the most part, with these algorithms, is educate people about it. The other thing, as we all know, is there are many biases that go into these algorithms, the generative AI as well as the other ones, because they're based on data from our society, which has problems. It's, not collected at random. And it's all kinds of factors go into that. And then when people develop these models and implement them, additional issues can occur. So we also want to avoid that. So when we intake AI to develop our strategy around it, we thought about each of these. Are people asking for something's needed? Is it useful? Do we know it's safe? If we don't know it's safe or useful, are we studying it so that we can understand that? Is it compliant, which is an increasingly complex issue? And then, what's the risk benefit ethics, and do they have a good evaluation and implementation plan, especially focused on training? So we've taken, as I said, over 150 through this model. That's actually how we developed this. And we said we really need to transform to bring these new capabilities that people are demanding and are excited about into our transformation to being a learning health system. So how are we doing that? Well, the first thing we did is look very hard about what we're missing in terms of our learning health system. And there's a maturity model that's been proposed by Jody Platt. And it basically focuses on like, who leads the learning health system in terms of its innovation and processes? How do you govern it? How do you manage it? How do you integrate quality and safety improvement? And what's the function of that? How do you engage the communities? And then how do you deal with data analytics and incorporate research concepts? And each of these has a set of things around them that are sort of defined in this paper. And what we did is we took a look at our experience in this. This is from a pragmatic trial that I've done. We've done a lot in research actually to do this, but it's been pretty separate from the leadership and the governance. Things were very siloed, and that our data and analytics and quality and safety infrastructure were really significantly they struggled to do this kind of especially cross-mission work to understand, not only what are we intending to produce as a health system, but also how can we better um, innovate in that, generate ideas and design solutions for them that we can learn from quickly. So we took this to our leadership and we said, with AI especially, we have to be addressing this. We have so many amazing new opportunities. They're expensive, so the value is unclear. If they aren't going to achieve what we think they're going to achieve, then we could spend a lot of money on that, which we don't have, and never see the impact. So that is how we came to this concept of the OHSU Center for AI-enabled learning health science, called SAILS. Uh, and its intent is to basically say we're on this journey to become a learning health system, our we think for the next 5 to 10 years, these new algorithms and capabilities are really going to drive a potentially positive disruption for us, bring back some joy to work and some of the things that we want to do. But we have to have a good system that we can rapidly evaluate, plan and evaluate these tools. So our goal is to really the mission is really to build this virtuous learning cycle, incorporating our AI, and that will lead in that. So I've already mentioned this at length, but again, there are so many places you could apply AI. What are the best opportunities? What knowledge is emerging, and what do we all want to do? That has to be organized. But we have to be able to accelerate change implementation and evaluation, especially with this new system of legacy that we're bringing in. So we also need to engage people on the front lines to drive this. So with some of the learning health system concepts and the building the learning communities, that's a crucial part of sort of our plan and our initial studies to really bring the people who are passionate, who bring the problems to us, to partner with them and give them the resources and time to help drive these models. So it's not about, us. It's not about the people leading the learning health system initiative. It's about all the people who work every day on it, and also bringing together these different cross-functional teams to drive to sort of adopt this culture where we're like, yes, things have to change. We are empowered to make that change, and we'll understand from this process what is working and what is not, and adapt. So, like I said before, we have these identify, design, and act process as part of this. And AI can be integrated in every single one of these areas. So, really understanding your data. AI is amazing actually at really taking all kinds of data, retransforming it, even generating insights to it, building new code for it. Um, Enabling you to do a lot more than we could before. So that's a crucial part as well. Many of our solutions are leveraging those models. So we really want to say, well, once we learn about a group that has a gap or their outcomes are worse than others, and we think we can address that by tailoring an approach. We can use AI as well now to have, especially through generative systems, to innovate and optimize in a way that was hard before. So, and apply that to care. And then, obviously we have ongoing analysis and insights as we're learning that can trigger our priorities. So in our model, it's basically a cross-mission effort that focuses on an executive group from the health system, from academics, from research. A colleague and I, Dr. Gold, who's more of the health system QI side, and I'm the informatics and research, although we both do both, to be honest, co-direct it. So we've got these different focus areas. And then as you see from the colors, we pull from health system, we pull from academics, we pull from research, and we have a council model. So the council basically helps us to shape and prioritize and as people have ideas, bringing them in to decide what are the most important things to do and to drive that forward. And then there's an operations core. And so the operations core, which is based, is really can be more thought of as bringing together the extant components that do this. So at the university, but the sort of tasking some of their time to work on this. So the informatics evaluation and data science operations group, for instance, is our CTSA group. That's the intent, that they're tasked to do that. They have staffing and some resources to do this, and they're sort of focused on that. Innovation and collaboration is a mix of some people who focus on industry collaboration, for instance, or bringing partners in, and people who focus on innovation, design, and leveraging these tools. So we have in each of these areas sort of groups that focus on our capabilities and efforts. Um, I really like this. Julia Adler-Milstein came from UCSF and talked about what they've been doing. And this is very similar. So at the top here is the Health AI steering. For us, we have an AI committee. And what they do is they sort of say, what are the most important areas that we should focus on? And then people sort of suggest ideas into this. And then there's a group like the cores that I just described that at the bottom here that are like, how do we make them work? Are they going to work? Doing a staging of initial evaluation to see, can it work? And then uh, once that's set up and evaluated and we think, yes, there's promise there, then we can sort of scale to more resources. So multiple sort of iterative cycles of these processes that go back and forth. And that's exactly our intent for the learning. The center will sort of drive this bottom part in conjunction with some different teams for prioritization and then make sure that we're making progress. So I'll finish and then I'm happy to take questions on how we did this first. So uh, the health system said we really think ambient scribes, these AI ambient scribes that record you and a patient and generate a transcript. That transcript is then fed into a large language model that generates a note. And we said, but they're expensive and we don't know how well they work. So we got two companies, and I'm going to, after this slide, de-identify them. But for the results, but Nabla and Aberage, you probably have one of those. Maybe of DAX or another one. There's like half dozen of them. And we basically had a 90-day trial with a 45-day with sort of crossover design to have 100 clinicians test these in the real world. They're quite easy to implement. I would say our training probably we could have had more, but all you do is hit the record button and then a note shows up and then you put that in your EHR, and that's the way it works. The note has errors in it a certain percentage of the time. I'll mention that. But we looked across the quintuple aim for, does this reduce documentation time? Does it reduce burnout, the time they're taking to write notes? Is there an ROI in terms of, quicker note production, and so we're more likely to get paid because the billing happens more regularly, or reduced turnover from morale issues. How accurate were the notes, and then how were they used? What was the use pattern, and was that inequitable? So those were our outcomes. This is an evaluation of a standardized set of, in this case, 14 cases, um, placed into an AI tool three times each. These are audio recordings of synthetic patient-provider communications with gold standard notes and transcription. And then these were compared for how often they left out key elements in the notes and then what percent of the note elements were correct. You can see that this one did pretty well overall, but for the A and P here on the right, you see there were a number of elements that were missing. The thing that you really is interesting is if you feed in the same input three times as on the left, it will get it wrong some percentage of the time, that they are not fixed, right? These are black boxes. And that's the other part, is that variability is very important to highlight the inconsistency. Um, Now, in R2, A and B, I'm just going to call them, only about 30% of notes had errors in them, but not insubstantial. And we actually rated those for harm. And, it was a small fraction in the thousands of notes people did, but people do have to go back and edit these notes. And we worry about automation bias because they look so good. So how were they used? We had about 16,000 visits where AI scribes could have been used during these 90 days. And A and B here are the two systems. They were only used about 37% of the time. Um, and roughly equivalent between them. So they didn't use them they only used them about a third of the time. This is very common. And they actually sort of used them a little less in the crossover in period two here. The use dropped. And part what we heard is they're like, this is frustrating. I don't want to learn another tool. Yes, it works. That's fine. But it was hard. It was hard to do that, which is an important part of this research. Some people use them, 60 visits a week. Some people use them 8 visits a week on average. So it really varied. Um, we did find our net promoter score, which is sort of like the people who'd rate them 9 or 10 to recommend it versus 1 through 6, was very high. So 100 is a perfect net promoter score. In the 50s, 60s, 70s is like very high. Most technology solutions are negative, so most people would detract them. And we got clear evidence they preferred one over the other. So that part was very useful. People also said after, at the bottom left here, that after they use this tool in both periods, but especially in period one, that their time for charting went from 30% sane poor to half that sane poor. So they had more time to chart, adequate. Mostly it moved to satisfactory time to chart versus before. So we did see significant time for that. A lot of people still felt like they only had marginal time available for charting. What we saw is an increase in same-day chart closure, but it was not persistent at the second time period. So that is something we have to restudy as we implement that. The quicker you do your notes in general and get them signed, the more likely you are to get your bill out and have that be paid. But we did see some reductions in reductions in the time per system today and time to note per appointment, although it wasn't universal across the systems. So efficiency seemed good, but not a home run. We did not see significant inequitable patterns of use. So who did they use it on? They actually used it on older adults more than other groups, which was very interesting. I think, that there is some aspect of complexity here. And they really didn't have significant issues otherwise. It's interesting. We have like a standard way we ask about, does a patient have difficulty with decisions, communicating, or hearing? And initially that was like a lower use, but it's so uncommon amongst the patients that it really, people still use them for those groups, which I thought was great to offer it. And we did ask for a patient consent on every single one of these. So that was our first big study. It was very successful. I think we got the information we need, and so they're able to go on to the next step to decide how are we going to scale this. We still have financial issues, but we have all the information we need about the right scale and the potential benefits. So I'll just finish there and say, these are hard things for systems to learn, and that a lot of our work in the next period of time is going to be really focused on that cultural, bringing up the teams and establishing this process to really enhance our capabilities to do this kind of innovation. So thanks. I appreciate your time and, a couple minutes for questions and be happy to take them.
Thanks, David. That was outstanding. One question, if you can share your slides, that will be terrific.
Yeah, so I sent a PDF of the slides to
Great,
Sean.
Yeah, sure.
So did you get them?
I do. I have them.
Yeah,
terrific,
so feel free to send them out.
Terrific. Thank you. I guess to get us started, first, outstanding talk. I really appreciate how you wove together activities from across the nation and what you and colleagues at OHSU are doing. Can you speak a little bit to the types of roles that are involved in these activities? Is it some sort of combination of clinicians, statisticians, informatics folks, health IT folks? What are the roles?
Yeah, that's a great question. Obviously I'm the Chief Research Information Officer, and my colleague Jeff was basically a quality lead for the Department of Medicine. Um, but we both do research. And I think for sort of leadership, you really do want people who can frame shift across missions, which we both do. We're both clinicians. We both have that. So I do think it's important for, for your leadership to understand across missions capabilities. What are the pressures on the health system, and how does that go forward? What can researchers do, and what might be the issues for research? Like we tend to be deliberative and expect efficacy trials, and then for education. I think how can we effectively and appropriately engage learners? For our kind of leadership, honestly, the engagement is, chief medical officer is involved, or chief nursing officer is involved, the dean of the School of Medicine and the chair of the Department of Medicine are heavily involved, as well as their quality leads. And then our in research really across our CTSA, and then one of our senior leaders are involved, and for them, as well as the some other leaders, and they really need to be involved to guide like what are the pressures, what will work, and having that cross mission. For people to fulfill the cores, it's very interesting. So we have, you know, for our first study, we work with a clinical reporting analyst, just because he knew enough about the kinds of data we need for research, but we're really using this to drive a clinical decision. But for our more complex pragmatic trial designs, our intention that we would have biostatistics and more of machine learning people. I will say in general, finding people who can do prompt engineering and understand how to measure things like hallucinations and other parts has been a crucial issue for us. And we've really focused on the few people locally that can do that. I think that's hard sometimes to find people who are willing to sort of do that. So we do have those kinds of people involved. The other thing, to be honest, though, for the team engagement, people who are very good at, engaging teams. We have a sprints effort where we're working on EHR optimization, and just people are really good at listening and sort of engaging and sort of drink the Kool-Aid about that kind of improvement. So mix. I mean, the intent is to have a complex, different set of folks. But really culture drives everything. So like they really have to be willing to adapt to the other disciplines and in order for the project to go forward.
Perfect. Thank you. Olivier, you have your hand up.
Hi, David. Great talk. So let me just fix my video. Here we go. I have two questions for you. I think I'm sure that you've addressed them in the past multiple times, but just curious to hear your answer. So one is, I think you mentioned that you have this governance committee that's looking at which tools or which AI models to test and deploy, but do you have like specific criteria for choosing the models or the tools, or is it all, well, I feel like this could be fine or this could be feasible? Like, is there like a checklist of some sort? Is there like a almost like a quantitative sort of assessment of the risks and the benefits and the feasibility? Uh, and maybe
Yeah.
you can address this one. I'll move on to the next one after.
Yeah, no, so it's very interesting. So it's a cross-mission committee. And so there are a few things where we're just like we really research and innovation, where like as long as you're compliant, we want to create capabilities for you. So we don't have that kind of expectations. And there's a few things that ethically, even for testing, people talk about. But the main issue there is that a lot of the researchers want to work with vendors that are going to use the data and with very complex models.
Right.
So we don't want to stand in the way of any research innovation, but we track those because we want to see as these models evolve, are we building the capabilities so they can implement them? So I know, Shannon McWeeny is on our team, and we talk a lot about some, multimodal AI has CLIA designations, for some algorithms for genomics, and some are just like testing, and we want to build a system that allows both, but can differentiate between them. So that's a lot of what we do. For implementation in the clinical space, there's no hard and fast criteria because a lot of these places have no evidence that their generative AI tool works. And so
Right.
then we say, if you want to implement this, some people we say this is actually innovation. Like you don't know that this works, so you need to test it. And that's fine. Test it. Here's the way you do that. And for some of them, we just build the evaluation so that we feel assured. But that is what the committee does. It just says you need an evaluation plan that meets this level, if that makes sense.
Yeah, it does. I guess my second question is about assessment and continuous monitoring and oversight in some ways. I'm sure again, things that I know that you've been thinking about, but there's tools that are fixed in time, right? Even the tools there's ambient listening tools, like there's, could be an update tomorrow, and then, it basically destroys or enhances dramatically the performance of the model. Um, how do you deal with that, right? So do you have like a fixed schedule of monitoring? Do you have like a dashboard? Like how do you deal with this stuff?
Yeah, this is the other reason for the center is that our algorithmic monitoring and quality assurance processes were just like not ready for this. And so Um, what we're trying to do is every study and every plan that we put in place, every tool that we put in place, we try and identify what are the ongoing monitoring requirements for this tool and then implement that. So for the ambient AI scribe, it's just what I showed. It's that we're going to monitor when and how they use them, and if that use pattern differs, and then we're going to look at the errors. So we're going to rerun these synthetic data in a regular basis. Like that's that. Now, for these other
But
ones,
is there somebody who's looking at it, like, which is practically speaking, like, do you have a person whose job it is to kind of, monitor, like look for emails that they come from the system, say, oh, there's like a degradation in performance, and let's
yeah,
do something.
yeah, I mean, this is the crucial issue that we're facing, which yes, we absolutely do have that, but it's
It's
really
almost like
not.
an air traffic controller for AI
Yeah,
models, right? Yeah, yeah.
yeah, but those capabilities really need to be advanced for multimodal data, and the the ARPA-H thing that the precise AI, really intended to say, what does that take? And how do you communicate that? And as we did that, like that's one of our blueprints for like what we need to be doing, but we're not there yet. And in some ways, if we think we can't monitor it well enough, we won't implement it. We'll say we have to do X to be able to implement it, and that's been the challenge. So that's an ongoing conversation.
Cool. Thank you.
Terrific. We are over time here, but many thanks to Dr. Dorr. Many thanks to everyone for joining today. Thank you. And as Sean indicated in the chat, for a copy of the slides, please contact Sean, as well as a copy of the recording. And I think there's a question in the chat, and Dave, I'll try to follow up with you and Dr. Udin about that. So
Perfect. Thanks.
terrific.
Thanks for having me.
Thanks,
Good to see
folks.
you all.
Appreciate it. Take
Bye.
care.
Thank you.